Hello, everyone, and welcome to LGBTQ plus Health Grand Rounds. My name is Wei Chen Ling. I use she, her pronouns, and I'm the program manager for Stanford Medicine's LGBTQ plus health program. For visual description, I'm an Asian woman with medium length black hair wearing a short sleeve green blouse today. And I'm thrilled to share the Zoom stage with our presenters to recognize Anal and Colorectal Cancer Awareness Month in March. Dr. Nikki Duong, Dr. Michelle Kahn, and our very special guest, David Russo of Cheeky Charity. Dr. Nikki Duong, he, him, is a board-certified gastroenterologist and transplant hepatologist. He completed his residency at Georgetown University Hospital and his fellowships at the Virginia Commonwealth University Hospital. He's passionate about health equity and patient-reported outcomes research with over 60 peer-reviewed publications. He enjoys mentoring the next generation and making the field of GI and hepatology more inclusive and welcoming from people from all backgrounds. He founded Rainbows in Gastro, a nonprofit organization established at the height of the COVID-19 pandemic, grounded in the pillars of patient advocacy, research, and mentorship. He continues to share his experiences at both the local and national levels. Welcome, Dr. Duong. Dr. Michelle Kahn, she, her, is a board-certified obstetrician gynecologist with training in reproductive infectious diseases. She's the founder and director of the PEACH program at Stanford, which stands for Prevention and Education of Anogenital Cancers and HPV-associated Diseases. She sees patients of any sex or gender in this program. She's active in professional societies, teaching national and international courses in high-resolution anoscopy on formulating guidelines for screening and management of HPV-related diseases. She currently serves as the president of the ASCCP, the Society for Anogenital HPV Disease, and as the secretary of the International Anal Neoplasia Society. Welcome, Dr. Kahn. David Russo, he, him, is the founder and executive director of Cheeky Charity, a nonprofit providing colorectal and anal cancer advocacy with a focus on the LGBTQ plus communities. With over 15 years of healthcare industry experience and a personal connection to the mission through his own early screening journey, David leads nationwide educational programs to thousands of healthcare providers and the general public. He's an active member of ASCO, the American Cancer Society's Cancer Action Network, the National Colorectal Cancer Roundtable, and the California Dialogue on Cancer. Welcome, David. Please note this session is being recorded and published on the Department of OB/GYN's public YouTube channel. For your convenience, we want to highlight a few of Zoom's built-in accessibility features to ensure everyone can fully participate. Zoom offers live automatic captioning, which you can enable by clicking the Show Captions button on the Zoom toolbar on the bottom of the screen. And if you don't see this option, click the More menu with the three dots and select Show Captions from there. You can adjust the size and appearance of captions in your Zoom settings under the Accessibility menu. We encourage you to explore these tools and use what works best for you throughout the chat or throughout today's session. And if we can help meet any additional access needs, please reach out to me via the chat at any time. And throughout the presentation, please feel free to add questions and comments directly in the chat as well. Dr. Duong will present first on colorectal cancer, Dr. Kahn will follow on anal genital cancers, and David will share about cancer screening advocacy and education from Cheeky Charity, and will lead the participant Q&A. And with that, I'm delighted to hand us off to Dr. Duong.
Awesome. Can you see my screen okay?
We sure can.
So thank you so much again to the LGBTQ plus health program for this invitation. I can say on behalf of myself and my co-presenters, we're super excited to be here today to kick off Colorectal Cancer and Anal Cancer Awareness Month. I'm going to start off by talking about my perspectives on how we can close the colorectal cancer gap with the focus on LGBTQ plus populations. So why are we talking about colorectal cancer? Because it's a disease with high mortality rates, as we know, but that is incredibly preventable if detected early. There's multiple screening modalities, and we know there's many disparities in access for LGBTQ plus communities. So my objectives are to review the epidemiology of colorectal cancer and current screening modalities, contextualize this for our patient population, and identify some practical and culturally competent strategies so that we can encourage and enhance screening. So let's start off with a quick poll. Which group do we all think has the lowest lifetime colorectal cancer screening rates? Is it A, gay men, B, lesbian women, C, bisexual adults, D, trans women, or E, everyone's favorite, unknown due to lack of data? So I'll give about 30 seconds here. And I don't have a prize, but maybe Wei Chen will have one for you. I'll reveal the answer at the end of this talk. Looks like a few more answers are trickling in. So it seems that the majority has chosen B so far. So moving on, so colorectal cancer is the leading cause of cancer-related death. This is a study that's hot off the press from January of this year from NCI. It looked at data from 1990 to 2023 of the top five leading causes of cancer-related death in the United States. Over 1 million people were included. The top five cancers being breast, leukemia, brain, lung, and obviously colon. Of those five cancers, unfortunately, the only one that showed a steady incline in age standardized death rates was colorectal cancer, and that was at a rate of 1.1% annually since 2005. The other four cancers of brain, breast, leukemia, and lung showed a decrease. So clearly, this has huge implications, which underscores the need not only for screening, but awareness and access to care. So when we think about colorectal cancer, oftentimes it's clustered together, but we should really be thinking about it in different segments because the risk factors are different depending on where we're talking about. There's obviously genetic risk factors, there's demographic risk factors like being female or male, being of different race and ethnicities. There's also environment. So we think about the high consumption of red meat in the American diet, sedentary lifestyle, sugary drinks, obesity, substance use like alcohol and tobacco, and then other conditions like IBD. You can see here that clearly these risk factors are not unique to whether somebody identifies as LGBTQ plus or not. However, being of a sexual and gender minority clearly can increase different stressors, and this can amplify the risk factors that I just mentioned. The signs and symptoms here, many of us think about anemia. Many of us think about persistent abdominal pain, rectal bleeding. However, also consider your patient who has unexplained weight loss, changes in stool caliber, and tenesmus, if we remember, which is that feeling of incomplete evacuation when you have a bowel movement. But the take home point here is not that patients present with signs and symptoms. It's actually the following. In the majority of cases of new colorectal cancer diagnoses, patients do not have any signs or symptoms, which is incredibly scary and alarming to think about. Screening saves lives. Every year, approximately 150,000 new cases of colorectal cancer are diagnosed. And if we look at new cases of colorectal cancer and patients who are less than 55 years, that rate has nearly doubled in the last 2 to 3 decades from 11% to 20%. Patients who are diagnosed at earlier stages when it's localized have excellent 5-year survival, approximately 91%. We know there's a surplus of data that links poor outcomes to socially disadvantaged groups, and that's not surprising to any of us on this call. But the data show that the majority of patients, approximately 60%, are being screened, and minority and 40% are not being screened. However, if you get a colonoscopy, it can certainly reduce the rates of colorectal cancer by an average of 40% and even reduce mortality by 60%. And so because of this, in 2018, the American Cancer Society actually changed the age for colorectal cancer screening from 50 years to 45 years, and this was later adapted in 2021 by the USPSTF. So let's keep this simple with the green, yellow, and red light analogy. In patients who are over 85, we do not recommend screening for colorectal cancer. For those patients who are age 76 to 85, it's based on shared decision making. And for patients who are age 45 to 75, we should definitely proceed with screening. So how do we screen? There's obviously direct visualization. If you're eating lunch, I apologize if you have a weak stomach for this photo here. But we do know that polyps do progress over 8 to 10 years, if not longer, from what's called a precancerous, maybe benign polyp or adenoma into an advanced adenoma. And then here you see, a central depression, ulceration, heaped up edges. This is colorectal cancer. So colonoscopy, by and large, is the gold standard. It's done at minimum every 10 years with high sensitivity and specificity, and all of our GI societies recommend it with strong, high level of evidence. Flexible sigmoidoscopy is a possibility as well. It can be done every 5 years. Obviously, it's only sensitive for distal colorectal cancer. It's good for patients who don't want to do the full prep because they can just do an enema right before the procedure. And this can be done unsedated, though I don't recommend it. And it's conditional evidence here. When we think about non-invasive methods, there's several out there. If you ask me, my preferred method is the second one here, which is the multi-targeted stool DNA test, also known as Cologuard. It's similar to the FIT test, but in addition to looking at immunochemical detection of hemoglobin in your stool, it also looks at DNA tests, and it's done every 3 years. Why is this good? It has high sensitivity, high specificity for colorectal cancer, but it can also detect things like sessile-serrated polyps and advanced adenomas that the FIT test cannot. However, our societies do give the strongest recommendation of evidence for FIT testing. CT colonography can be done every 5 years, and that's what you see here pictured on the right. Typically, for me, I order this if a patient undergoes colonoscopy with me and it's difficult. It's either very tortuous, it's twisty, or the colon's redundant or so-called floppy. But the downside is if you do the CT colonography and you do see something like a protrusion or polyp here, they'll have to undergo a colonoscopy again. There are blood tests out there like next-gen sequencing and even Septa9. However, it's not ready for prime time, in my opinion, and a lot of our GI societies are recommending against this. So how do you approach a patient with a family history of colorectal cancer? It's very confusing. So if you ever have a question or when in doubt, just reach out to one of us in GI and we're happy to help you. But the bottom line is to remember if your patient has a family member who was diagnosed with colorectal cancer or an advanced adenoma before or after the age of 60. Why is that? Because if the patient's sitting in front of you and their first degree relative has colorectal cancer or an advanced adenoma less than the age of 60, or two or more first degree relatives at any age diagnosed with cancer or an advanced adenoma, we actually drop the screening age from 45 to 40, or 10 years before the earliest diagnosis of colorectal cancer. And then the interval is important to remember here because it's repeated every 5 years. Now, if you have that a different patient with a first degree family member with colorectal cancer or an advanced adenoma greater than or equal to 60 years old, or two or more second degree relatives with colorectal cancer at any age, we actually start at age 40 as well. However, the repeat interval is the same as an average risk patient. Again, very confusing, but I just wanted to put this up here for reference. What's an advanced adenoma, by the way? It's any polyp that's greater than 1 centimeter, villus pathology, high-grade dysplasia, or sessile-serrated polyp. So as was mentioned in 2021, at the height of the pandemic, I was in my GI and liver fellowship, and I realized the dire need for more research in understanding digestive health needs for our LGBT patients. I realized there's a lack of representation of it at the societal leadership level, a lack of mentorship and advocacy. So I decided to start this nonprofit, and now we're in our 5th year. And I've tried to bring the work that we do on a national level here on a local level to Stanford, and which is why I started this LGBTQ plus digestive health program. We all know because I'm preaching to the choir here that it's so important for us to have providers who, care, who understand, and who have this lived experience. And why is that? Because the data is right here, and we published this year. We had almost 1,000 LGBTQ plus and non-LGBTQ plus GI and liver providers who answered our survey. And what we found here, as highlighted in these blue boxes, is that non-sexual and gender minority providers really don't feel comfortable not only communicating with LGBTQ plus people, but they also don't feel confident in treating LGBTQ plus people. We always say that the data is scarce, but fortunately, it's not too scarce in this field of study. What the data do show is that lifetime colorectal cancer screening rates are actually quite high in gay, lesbian, and bisexual patients. However, this is the answer to the poll previously. It was lowest in trans women and transgender non-conforming individuals. What was the most important predictor of if a patient gets screened or not? Based on the systematic review, it's actually communication. It's communication quality, adequacy and strength of communication, and rapport with the provider. So that's incredibly important. We should also be thinking about the neovagina in patients who are male to female. Why is that? Because during a vaginoplasty, even though typically penile tissue is used, at times intestinal graft tissue can be used. And obviously, that tissue is at risk for turning into or developing polyps and colorectal cancer. However, how often and when we screen those patients is still not known. So I'll briefly cover some of the barriers which many of us know being in this field. Patients have had past negative experiences, and that can influence whether or not they get screened and enter our healthcare system. There's a lot of anxiety often regarding misgendering and distress about anatomy during these very private exams. Provider perspectives, thankfully, this is not a problem in terms of limited training. We have a ton of it at Stanford, but across the country, we all know this is not the same landscape that our colleagues are facing. Um, in terms of systems level barriers, we know that a lot of EHR systems do not collect SOGI data. Thankfully, this is also not a problem for us here at Stanford. There's a lot of clinics that are not affirming across the country, and oftentimes there's structural stigma. And what do I mean by that? A lot of our systems and healthcare policies are by default built to reinforce this heteronormativity, and that cycle really has to be broken in order for us to have change as we know it. The disparities that I've mentioned so far in this presentation, though, are not behavioral. A lot of them are structural. So how do we put this all together? We know that LGBTQ plus adults really avoid healthcare due to discrimination and many other complicated factors, but screening does save lives. And unfortunately, a minority of Americans are not being screened who are at most risk for colorectal cancer. So providing culturally sensitive care is incredibly important. This is a bit blurry here, but it's blurry because I want to show you that this is a life quote that I get in Epic and through my emails quite often from providers like yourself. I highly welcome them. Please send me more messages like this. But it's always surprising to me when I hear about these stories and incredibly disheartening where patients who identify as LGBTQ plus avoid screening and avoid care because of fear, because they don't want to be teased, they don't want to be made fun of. They're not sure how providers will feel about them. And so it's really important for us to provide culturally competent care. And after this experience, we really have huddles now when we have patients like this who reach out to us. I ensure that our team utilizes the correct pronouns for our patients. We've even had patients of domestic violence who've reached out to me and said, look, I don't want to get a colonoscopy because I'm really scared. What can you do to help me? So what we do, we show them photos of the endoscopy room before we bring them back. We minimize monitors and excess beeping. We change the lighting. We wait to expose the patient's backside until they're fully asleep. And these may seem like really small actions, but for patients, these are huge. And so what I've done is I've turned these things into a paper. We've written about this in trauma-informed care in terms of in the endoscopy suite. And there's a lot of phrases now that we should think about because how we speak to our patients really can have a profound impact, be it positive or negative. Saying things after they get their colonoscopy, like your colonoscopy looked good, are not appropriate. Being mindful about how we word things and telling our patients that their colon looked healthy is much more appropriate and important. These are some other phrases that I've taught myself over the course of being a provider. No one's really taught me this in my training, but things I ask my patients are what do they go by rather than assuming that somebody's Mr. or Mrs. I ask patients, is there anything else we can do to make them more comfortable? I tell them that I do recommend a colonoscopy, and if it's appropriate, what can we do to make them feel safer? And some, actionable steps, we always need to partner with you all as our primary care providers at the front lines. We need to promote colorectal cancer screening at Pride events, for example, have a list of culturally sensitive providers, make sure our office spaces are LGBTQ plus friendly. And we need to identify cancer survivors who've walked the walk and have this lived experience so they can help share their story for the patients that come after them. So my take-home points are that colorectal cancer is often a silent disease, but we know that screening saves lives and disparities are often modifiable. LGBTQ plus patients do face a ton of barriers that I've mentioned that are often unrelated to biology, and access to affirming care is not just an option, it's a fundamental right. Thank you so much for your time and attention, and I'll hand it off to Dr. Khan.
Thank you, Dr. Duong. That was really great. And I would say that a lot of what you spoke about in terms of providing inclusive care will apply to anal cancer screening as well. So I'm going to go ahead and share my slides. And can you all see this full screen?
We sure can.
Thank you. So again, my name is Michelle Kahn. My pronouns are she and her, and I run the Peach program here at Stanford. My disclosures and positionality are that I identify as a heterosexual cis female of Guyanese Indian descent. I started doing high resolution anoscopy in 2012 as an extension of my work in gynecologic cancer prevention. and I'm involved in committees and work both locally and on the national level to advance health equity. Wei Chen mentioned my involvement in professional societies that work on HPV cancer prevention. And in this talk, I will be discussing off-label use of screening tests. So here's a poll, if you could fill this out. Who should be screened for anal cancer? A is all people who have had receptive anal sex. B is men who have sex with men living with HIV, age 35 years or older. C is transgender women who are HIV negative, age 45 years or older. D is answers B and C, and E is none of the above. I'll give you a few more seconds to answer. And it looks like 73% said A, all people who have had receptive anal sex, and 27% said B and C. So I will be sharing with you later on in the talk the screening guidelines. So we'll answer that question. In terms of anal cancer epidemiology, it's not as prevalent as colorectal cancer. And for that reason, we have targeted screening guidelines. But it is rising in incidence, and there are 11,000 new cases expected in 2026, with 7,700 in women and 3,570 in men. And there's 1,700 deaths on an annual basis. When we look at racial ethnic groups, we see that it's most common in white women and in Black men. And we know that the rates are rising. Here you can see the rates are rising at a rate of 2.2% each year in the light green. And in the dark green, you can see that mortality from anal cancer is also rising, not as sharp of a rate, but still on the rise. This is a meta-analysis looking at incidence rates of anal cancer. And here's where you can see the disparity in terms of incidence when they divided it up based on the literature. And this is one field where we do have a lot of, most of the literature is in men who have sex with men and in people living with HIV. So patients at higher risk, there's a lot of data, and they were able to put it all together in this meta-analysis. You can see the highest risk group is men who have sex with men living with HIV. And when you divide that up by age, older ages are at higher risk. The average age of anal cancer is around age 60. And so we do see it happening at older ages. The risk is still high, though, in patients that are in that 30 to 44-year-old group. When we look at MSM who are HIV negative, we see that they're at increased risk above the general population, which is about 2 per 100,000. And here they're at about 18 per 100,000. When we look at men who don't identify as men who have sex with men, who have HIV, their rates are very high as well, as are in the females living with HIV. And when we look at females with other risk factors, we see that vulvar lesions, precancers, and cancers are very high risk for anal cancer, as well as immunosuppression in the form of solid organ transplant for at least 10 years. And you can see below that one, it's really the length of immunosuppression that leads to the increased risk. So from this meta-analysis, you can see that the highest incidence of anal cancer is in the MSM group. This is a landmark study called the Anchor Trial that was published in 2022 in the New England Journal of Medicine. And this study showed that we can prevent anal cancer by treating precancerous lesions. It was a multi-center study at 25 US sites. They had almost 4,500 people living with HIV. They were age 35 and older. They all had precancer, or anal HSIL is the technical term for precancer, high-grade squamous intraepithelial lesion. And these patients were randomized to being treated or actively followed every 6 months. and they were supposed to be followed for up to 5 years. The trial was stopped prematurely because they saw a higher rate of cancer development in the patients that were being monitored versus the patients that were being treated. And so they stopped the study and recommended treatment for everyone. The rate of progression to cancer was 57% lower in the treatment group. And here you can see in terms of gender identity and sexual activity that the majority of the patients were male, about 80%, 15% were female, and about 3 to 4% identified as transgender. When we look at sexual contact, 77% were reported male to male sexual contact, and 24% reported being heterosexual. This is the Kaplan-Meier curve of development of anal cancer throughout the course of the study. And the red line are the people who got treated for their precancer, and the blue line are people who were being monitored and did not get treated. And there was a significant difference between the two in terms of lower development of cancer in people getting treated. So this study shows us that we can decrease rates of anal cancer. There was a study from the Netherlands that showed that we can decrease morbidity and mortality from anal cancer with screening. And in the Netherlands, they introduced screening in 2007, and they followed patients over time to see how the rates of anal cancer changed. And in this study, 59% of the participants were MSM. Here you can see that screening decreased mortality from anal cancer. These dotted lines are people that got screened, and this is mortality split up between all-cause mortality and anal cancer-related mortality. And there was a significant difference between the people that got screened and the people who didn't get screened in terms of higher mortality in those who did not get screened. When they looked at the stage at diagnosis, they found that there was later stages at diagnosis in people who had no screening, and that's these more orange colors. The people who had screening were able to get their cancers detected at earlier stages of diagnosis. And so we know that screening may not prevent all cancer, but it can detect it at an earlier stage, and that can improve morbidity and mortality from anal cancer. We also know that there were no screening guidelines for LGBTQ populations, and many misconceptions and barriers to screening for the HPV-related cancers. And so this group, we got together and reviewed all the literature. We wanted to address some of these misconceptions, such as women who have sex with women do not need cervical cancer screening or may have been told by their provider that they don't need cervical cancer screening. There's a lower rate of screening in trans men with a uterus, and this may be due to discomfort and dysphoria with the pelvic exam. We know that transgender, non-binary patients may not come in for healthcare due to prior experiences with stigma, and we know that the MSM and trans female population are at high risk of anal cancer. And so we looked at this data and provided some recommendations for screening for HPV cancers. With regards to trans men, we know that there's challenges in cervical cancer screening. Testosterone, which is used as gender affirming therapy, often leads to changes in the vaginal and cervical epithelium, which can make speculum exams difficult, and can also lead to higher rates of unsatisfactory cytology. We also know there's a subset of trans men that may identify as MSM and engage in receptive anal sex. This group is not currently identified as a high-risk population for anal cancer. However, there's really no data on this group. So I think as time goes on, hopefully we'll get more data. With regards to trans women, we know that they're a very high-risk group for anal cancer. They have a unique vulnerability to HIV and HPV. With regards to gender-based discrimination, violence, victimization, and social marginalization, which can lead to limited social and economic position. So there's higher rates of sex work as a means to survival, which can lead to higher STI rates. And with increased STIs, you have a greater risk of acquiring HIV. And we know that with HIV, you're more likely to get HPV and not be able to control the infection. And when we look at the anal HPV prevalence rates in trans women, they're as high as 97%. And there's not a lot of data on the anal precancer prevalence rates in trans women, but the rates that are published are about 58 to 59%. So very high rates of precancer. When we look at MSM, we already showed the graph showing the highest risk for incident anal cancer. One other disparity that the MSM population has experienced was the girls only vaccination that was initially recommended with the HPV vaccine. And the vaccine was initially recommended for girls and then was expanded to high risk boys before it got expanded to all boys. We know that there was some herd immunity that heterosexual males experienced with vaccination, and the MSM were excluded from that effect. Here you can see the rates of genital warts that really plummeted with the effects of the vaccine, and that was also seen in heterosexual males, but not as much in MSM population. So when we published our recommendations on screening for HPV-related cancers in LGBTQ populations, we really wanted to focus on organ-based screening rather than screening based on risk group. And this was our recommendations. So if there's a cervix, we recommend screening. Cervical cancer screening is recommended for the all of the population of people that have a cervix. If they have an anus present, those with higher risk should get screened. And this was published prior to the International Anal Neoplasia Society's screening guidelines that came out. We also make recommendations for oropharynx, vagina, vulva, and penis. So these are the guidelines that were published in 2024 from the International Anal Neoplasia Society. And these are the guidelines that should be followed currently for anal cancer screening. You can see that there's two risk categories, A and B. A is the group that is at highest risk, which includes men who have sex with men and transgender women. And if they have HIV, to start at age 35. If they don't have HIV, it would start at age 45. And then you also see in this highest risk group, risk category A, you see men non-MSM and women living with HIV starting at age 45. You see the people with vulva dysplasia or vulva cancer and solid organ transplant recipients. So all the people at highest risk on the graph that I had showed you previously are recommended for screening. So the answer to the initial question was that groups B and C, which was the MSM living with HIV, age 35 and older, and transgender women, HIV negative, age 45 and older, should be screened for anal cancer. There's this other risk category, which are people who are at increased risk but not as high as risk category A, and it's recommended to do shared clinical decision making starting at age 45 to screen those patients. Now I'm just going to move on to how do you screen for anal cancer. There's two main ways. Digital anal rectal exam is one of the ways, and the other is to use a test, an anal cancer screening test, such as the anal cytology, which some people call an anal pap smear, or HPV testing. The HPV testing is not FDA approved in the anus, but it has been shown in many studies to be very effective at screening, and so that's what's used currently. And then if anyone has an abnormal result on their screening, they go on to a procedure called high resolution anoscopy. This is just to show you the anal anatomy, and the anal canal is about 2.5 to 4 centimeters in from the anal verge. And this squamocolumnar junction, where the tissue changes from the squamous tissue of the anus to the columnar tissue of the rectum, is the area we're trying to sample when we do an anal cytology or when we do an HPV test. So the swab goes in about 2.5 to 4 centimeters. When we talk about these tests, there's also more and more data coming out on self-sampling as another way to screen patients, and this might be a way to get more patients screened. I know David's going to talk a little bit about screening in the community, and this is one way that it could be performed. Again, it's not FDA approved, but there's more and more data coming out that this is a good method for screening. When they look at HPV self-collection versus clinician collection, The sample adequacy is comparable, and there's no significant difference in the prevalence of HPV. When they look at the anal cytology, which is looking at actual cells that are picked up, there's a slightly lower sample adequacy by about 10% and no significant difference in terms of abnormalities. So I think this is a really up and coming, promising way to screen people. When we talk about the digital anal rectal exam, or DARE for short, that's really palpating to see if you can pick up a cancer early. The goal is to be able to identify lesions in the anal canal and refer patients on for biopsy and diagnosis. And if you don't have high resolution anoscopy available as a follow-up procedure, this would really be the mode of screening for anal cancer. And any patients that have an abnormal DARE would be referred on to colorectal surgery for biopsy. And again, we're going in about 2.5 to 4 centimeters to palpate 360 degrees around the anal canal, feeling for any nodularity, any irregularities, any lumps, any areas of tenderness. Sometimes people have soft tags in the anus, but anything hard, irregular, you'd want to have further exploration. And then finally, looking at vaccination in LGBTQ populations, what the studies have found is that there's very low rates of provider recommendation. In this study, they found that only 9 to 10% of providers were recommending HPV vaccination in LGBTQ patients. And what we know for vaccination is that the provider recommendation is really the primary facilitator for vaccination. So that's something that we would recommend that providers recommend to their patients that are eligible for vaccination. You can see here the rates are a lot higher when it was recommended versus not recommended. Just to speak very quickly about our program, the PEACH program, we're located in Palo Alto, and we offer consultation on anogenital dysplasia. We do colposcopy of the lower genital tract as well as high resolution anoscopy, and we do treatment of both warts and precancerous lesions. We do offer HPV vaccination, and we have most of our procedures are performed in the office, but can also go to the operating room as needed. We offer several different levels of sedation for these procedures for pain control. So in summary, we know that LGBTQ plus populations are at increased risk of anal cancer, and we know that screening and treatment of precancers does prevent development of cancer, can detect cancer at an earlier stage. Screening guidelines are now published and available and should be utilized, particularly in areas where high resolution anoscopy is available for the anal cytology and HPV testing. And where HRA is not available, the digital anal rectal exam, or DARE, should be performed as a screening test. And finally, HPV vaccination is the best prevention. And the younger we can give it to patients, the more effective it is, but it can still be beneficial for people with ongoing risk factors. And so we recommend that providers do recommend vaccination to their patients to increase rates of vaccine. Here's my contact information. And then I will hand this over to David Russo.
David, you're muted as well.
Yes. Hi. All right. Let me just share my slides. Let's see. No, not that. 1 second. Sorry.
Although I'm sure butts and badges will come up in your talk. And if it doesn't,
Yes.
it should.
Can you see my?
Yes, that's perfect.
Okay, awesome. Hi. So yeah, I'm David Russo. Um, let's see if I'm the founder and executive director of Cheeky Charity. We're an LGBTQ plus focused colorectal and anal cancer advocacy organization. We, well, for the sake of time, I'm going to talk briefly about our Butts and Badges program as an example of a program that's being leveraged to facilitate conversations about everything that's been discussed today. And I have some information about conversational concepts as well in the primary care setting. So as mentioned, what we're doing as Cheeky Charity is leveraging this visual icon of a heart that looks like a butt to facilitate a conversation. The idea is that providers wear it next to their badge or on their lanyard, and either the patient sees this and initiates a conversation directly, or the provider can kind of use that pin as a touch point to initiate the conversation themselves. I feel this is relevant, and it's showing up in research where a study from Dana-Farber showed that by showing visible signs of allyship, and allyship could mean the spectrum of not just LGBTQ, but an ally of anybody facing any kind of health disparity. Having those visible signs increases patient comfort discussing sensitive topics by 43%. Significant benefit for something that's so simple to incorporate into your healthcare setting. And what we're doing for our program is incorporating a little business card, like a participant card, along with the PIN to give providers an opportunity to have some useful information as they're preparing to have these conversations. We have some pamphlets as well. I think I'll talk for maybe 2 or 3 more minutes, and then we'll jump right into a Q&A. My focus is on the Federally Qualified Health Centers, or FQHC, platform. And I think you could see here that, while the national average for colorectal cancer screening rates is 69%, we are facing larger disparities in the clinics that are providing services to the folks that are more likely to be facing barriers. The other thing to keep in mind is, I really like to highlight this, is that a provider recommendation is the single biggest motivator for screening. So while you can give somebody a flyer or give somebody information or send them a link, at the end of the day, the thing that's going to statistically move the needle the most is by having a provider initiating that conversation and influencing or recommending a screening in order to best influence their patient response. And I think this might be a good place to end. Is the thing that we really want to watch out for is the dismissal issue, where it's easy for you to think to the most obvious possibility of what something could be, and saying, oh, you're too young, so it's probably something else, or it's probably just hemorrhoids, or let's wait and see. That's what leads to this diagnostic delay, which we found in colorectal cancer to be 6 months. And for anal cancer, we don't even know what the diagnostic delay is because we don't have that research, but we know it's significant due to both the stigma around the conversation and just the lack of screening options in a large swath of the country. So I think with that, I'd love to say thank you so much for having me here to talk and to present. And I would really love to help facilitate the Q&A and hear what you all are thinking from this amazing conversation that we've been having.
Thank you so much, David. And again, welcoming folks to come onto the mic to ask questions, or if you'd like, drop the question in the chat. And if you'd like to speak on the mic, we just ask that you use the little raise hand function so that we can keep track of who all has a question in mind.
There was a raised hand during the presentation. I'm looking to see.
Oh, yes, I think it was Dr. Tordoff. Are you still on the call and would like to ask your question? I think Diana had to jump off. We're welcoming any questions from the group.
While we're waiting for any questions, I thought maybe, David, you could talk about what you've done at Pride events for screening and awareness.
So yeah, we have been really fortunate to have been last year we went to 55 Pride festivals across the country with a 10 by 10 exhibitor booth where we had basically we used our cheeky kind of concept to facilitate engaging with people at Pride festivals. You know, at a place like that, you want to, or at any place you go to, you want to fit into the environment. And so we did our best to fit into the vibe and the feel of the experience. And so we go out there and um, I'm just pulling up, you know, I do things like I put on a fake butt and shake it around to share information. And you can see I'm in front of a large inflatable colon, which we bring out to as many prides as we can. Um,
I think y'all did a Halloween spooky colon in SF, right? During Halloween, October last year, which I was jealous didn't get to go to, but it sounded amazing.
yes, you have to come next year. Yeah, that was a unique opportunity. We were always trying to find ways to be creative, and a spooky haunted colon was as unique as I felt like we could come up with.
And one thing I know some folks have ordered, so they did but these butts and badges. So some of us have them and are wearing them for March to raise awareness. And I actually heard from a CRC today who somebody actually said, "I love your butt." And she was like, "Oh, that's awkward." But then she was like, "No, no, no, your pin." And she was like, "Oh yeah, I'm wearing it for this month and raising awareness." So it worked. Um, I can ask a
Mhm.
question, but I see some questions coming in the chat. But just I think you might have touched on this, but just to go back over the vaccines like Gardasil, I get a lot of people who ask questions about like if I'm older, should I still get that? If I think I already have symptoms, is it worth getting? Does it help decrease any development of HPV related cancers? And so just to touch on that for a second, what's your advice there?
Yeah, so the Gardasil is approved by the FDA for ages 9 through 45, and it's ideal to give it before any exposure to HPV because it is a prophylactic HPV vaccine. That being said, we know the effectiveness rate is extremely high in people that are HPV naive. It does protect against 9 different types of HPV, which are the 2 types that cause the majority of genital warts and the 7 types that cause the majority of cervical cancers and anal cancers, and oropharyngeal cancers. And so we know that it's type-specific immunity and that not everyone will have been exposed to all of the 9 types. And so if patients have been exposed to one but not the other, they could still get some benefit from getting vaccinated if they have ongoing new exposures to new HPV types. And so a lot of my patients get it, that's where the shared clinical decision making comes in for the 27 to 45-year-old age group. If you have a patient that is sexually active with multiple partners, then they may be getting new exposures and they may benefit from the vaccine. If you have someone who's in a long-term relationship and likely is not going to have new exposures, they may not benefit from the vaccine. It's also been studied in people with anal precancer to see whether it would reduce recurrence of precancer. We know that the precancers have a high rate of recurrence, and we often have to treat multiple times. There were some randomized controlled trials looking at this, and unfortunately, they did not show efficacy in prevention of recurrence. And the anus is a little bit different than the cervix in terms of treatment of the precancers, in that because people use their butts every day for going to the bathroom, we can't have we can't have really, invasive treatments. And so our treatments are either topical or ablation, where we get rid of that surface layer of tissue that contains the precancer, but we can't cut out a big chunk of the anus because people need to heal and continue to poop every day. We do excision when we're worried about cancer, and in those cases we refer to a colorectal surgeon to do that. But for precancer, the treatments are not as effective as we would like. And so there's ongoing research into that. But the vaccine studies have not shown that it'll decrease the recurrence of anal precancer, but we know it's effective in terms of prevention of HPV types that you haven't been exposed to in the past.
Thanks so much, Dr. Khan. And there's a question in the chat. I'm curious, what are the group's thoughts on doing the at-home colorectal cancer screenings, like through LabCorp? My PCP says I was too young, so I paid for one out of pocket. What are y'all's thoughts?
Yeah, I'm happy to start and take this one. So I would say, these non-visualization tests, such as everything but colonoscopy, is really intended for average risk patients, probably like yourself. If you are at risk, meaning you have symptoms, you have a family history of colon cancer, you have inflammatory bowel disease that's been previously diagnosed, then, clearly colonoscopy is the way to go. But these other tests are very accurate. However, everything has to be taken with a grain of salt. And I say that because more anecdotally, yes, there's data, but from what I've seen in my practice, I've had many of patients who do these stool tests and they come back negative, and then, for some reason they stumble upon me and do a colonoscopy, and then we find polyps that are precancerous. Not to say that this should cause alarm, but it's just something to keep in mind. I think also there's a lot of questions often about the screening age and how it dropped from 50 to 45, and will it continue to drop? We all probably heard recently about the news about, the actor from Dawson's Creek. And so I would say, there's a lot of studies now ongoing about if it's worthwhile and I guess economical from a public health system's perspective to continue to drop the age. Currently, our societies are holding steady and strong at keeping at 45. I suspect the future will change, though.
Thank you. That was really helpful. And I guess I only have a few more years then.
And on that note, I'm kind of curious, y'all's thoughts. If someone is like at home noticing like changes in stool, feeling discomfort, but they're not sure, like where I meet some of the symptoms, but not all of them, at what point should they consider seeking clinical care?
I would say they should seek clinical care if they're noticing changes and make an appointment with their primary care. And at minimum, the primary care can do an exam to check for any lumps, any irregularities. They can look at the outside to see what might be the cause of that sensation. And then they can refer on if it's warranted for further evaluation.
Yeah, and I know Dr. Duong had mentioned that many cases of colorectal cancers don't have initial symptoms or signs. So, David, from your perspective in terms of advocacy and education, is there any sort of one-liner piece of advice that you hope folks take away in terms of advocating for themselves and their care?
I mean, I basically split it into the under 45 and over 45 group. For under 45, the key takeaway is you think about symptoms, think about family history, um, and and really focus on that. And for the over 45 group, it's like make sure you're up to date with your screening. I think, you can try to de-emphasize symptoms a bit for the over 45 group. Not to say they're not important, but to say like, most cases or a lot of cases don't have any symptoms. So regardless, get your screening. And if you want one takeaway, it's if you're over 45, you don't know if you're healthy. You can't really say you're healthy until you've gotten screened. Once you're screened, then you could say like, okay, I know at least from that perspective, I'm healthy, but you don't really know.
That's a great takeaway for everyone. And from the nods I was seeing on the screen, it sounds like that resonated with a lot of folks and maybe prompted a little call to action for folks on the call. Well, thank you so much again, Dr. Khan, Dr. Duong, David, for joining us today. I'll just close out with a few very brief updates and upcoming events from the LGBTQ plus health program that I'll share on the screen now. So you all have attended our February grand rounds today, and hopefully you're walking away with a lot of new knowledge on anal and colorectal cancer screening, education, advocating for yourself and your patients. We do grand rounds on LGBTQ plus health every month, and our March grand rounds will feature Dr. Blair Peters, who is a national leader in gender affirming surgery at OHSU and who will be coming to Stanford to do a talk on the state of gender affirming surgery, where are we now and where are we going. So we invite you to join us either in person or virtual for this event. In person, of course, strongly encouraged so that we can give a warm welcome to Dr. Peters in CAM. The week following that, in mid-March, we welcome Dr. Tabia Hassler from the University of Zurich, who will share their global health project on the global LGBTIQ health project, connecting LGBTQ plus databases, patients, information, education across several continents. So we invite you to join us at this hybrid event on Porter or virtual via Zoom. And finally, at the end of the month, we are having our monthly community outing event. This is a series of community socials that we put on, and all Stanford community are welcome. We are showing a film screening of Heightened Scrutiny, which follows Chase Strangio, who's the ACLU attorney, who was the first out trans person to argue before the Supreme Court on the Scrimeti case. This is a documentary that has been shown at Sundance and many other notable awards for films. So we hope you'll join us in this debut of Heightened Scrutiny at Stanford. So with that, the registration links for our upcoming events are in the chat. I want to thank our presenters once again for joining us for this incredible hour of education. And I wish everyone a great rest of the week. Take good care and happy Anal and Colorectal Cancer Awareness Month starting next week.
Thanks, y'all.
Thanks, everyone.
Thank you.
Great job.